So Brittany's a patient who suffers from chronic neck pain and headaches. The pain is going down both arms.
Mainly the left.
That's your right.
The right.
Okay. Mainly the right side. She's had in the past a combination of brachial plexus blocks, occipital nerve blocks, trigger points, accessory blocks, paravertebral nerve blocks, and it's given her over 70% relief. She's way better than she was a month ago when I believe I first met her. And now she wants just a repeat of the same therapy to keep at it and prevent the pain from getting worse again. Since she's had these injections, she's been able to function better at work, etc., correct? And do more. Your activities of daily living are easier.
Yeah.
Okay.
Yep.
Very good. So we'll start. The pain goes down the right arm to her pinky.
Yeah. And then it'll go to each finger.
Does it go to the thumb?
No.
Okay, so it's basically radiating more towards C7. So we're going to first find the supraclavicular brachial plexus by the subclavian artery. And we're going to trace it back up to her neck to the interscaling brachial plexus right here. Decrease depth, decrease depth, decrease gain. And just a little flick of the wrist, how I move my ultrasound, you see the nerves appear differently. They appear as a stop sign, one on top of, a street light, one on top of the other, or the snowman sign. And increase depth, I could trace them back to the foramen. As you see, they're disappearing.
And C6 is entering at the foramen here. You could see the anterior tubercle chassis nags of C6 anterior to the nerve.
Let's make sure there's no blood vessels in the vicinity. Color mode. Okay, it looks like we're free and clear. The vertebral artery is anterior here and well away from where we want to go. B mode. Capture image. No pinch. Anything shoot down your hand, just let me know, okay?
Yeah.
Negative aspiration. We get a little closer to the nerve. That was closer to the medial branch because that travels posteriorly. You may feel something down the arm now. Are you there, all right? Yeah. A little bit at the 12 o'clock position of the nerve to avoid touching it. Still good?
Yeah.
All right, we're right around the nerve. Going down your arm?
No.
Okay, it doesn't have to. But capture image, you see the needle is 12 o'clock of the nerve, and it's also between C7 and C6. C6 is above, C7 is below. Scanning downwards, I see the articular pillar, where I could do a paravertebral block, as well as get into the facet capsule. Right here. This will get the facet joint as well as the medial branch external to the joint, which is a little hard to see, but it's over there. Doing good?
Yep.
Okay. You have pain higher or lower than this point?
A little bit lower.
Okay, right here?
Yeah.
Okay. And here we could see the articular pillar again. A little pinch. A little trigger point here on the way in.
Yep.
Get her trigger points as well. That's right here is an articular pillar, facet capsule, as well as the medial branch. Once again, hard to see, but it's there. Now we're going to do her occipitals. Scanning the spine, can you just look down, please? At C2, the first spinous process is bifid. And we just scan laterally. We see the obliquus capitis inferior muscle, decreased depth, and the semispinalis muscle. And between them lies the occipital nerve. And it may appear as one branch or more than one. This is the greater occipital nerve before it joins the artery. A little pinch. Right there. Capture image. Just going to go a little closer to it. And just getting in that plane will dissect. The medication will just hydrodissect over towards the nerve, above the needle. Right here, now centered. Are we doing good?
Yeah.
Okay. Here is the sternocleidomastoid muscle. Posterior to it is the region of the superficial cervical plexus. And analgesia of the plexus will get the transverse cervical nerves, little pinch, as well as the lesser occipital nerve, and give some relief to her for her headache and neck pain as well. Capture image. Pausing a small amount over there. And sometimes you can see the accessory nerve as well, which should be leaving the sternocleidomastoid heading towards the trapezius, and it's quite superficial, and it's 8 centimeters superior to the clavicle, and I would judge it's in this plane right here, little pinch. Right there. Capture image. There we go. Just a small amount of local there. I think I have one more thing left to do. Are you okay?
Yep.
Have you had enough, or do you want me to continue?
I'm okay.
I'm going to do this to suprascapular nerve blocks. So I'm scanning over the trapezius and supraspinatus muscle, looking down at the spine of the scapula, focusing in, decreased depth, at the transverse scapular ligament where the suprascapular nerve lies. And I'm going to deposit a little bit of local anesthetic just to give her some relief of the pain that radiates towards the back of her shoulders, a little pinch. Yep, sorry. Right down
You
above.
twitch.
I know, it will do that. It's going to go a little bit more shallow because it was close to the artery. And we're perforating the ligament now. And there we go. Nice spread over the nerve. Needle mode. There we go. Right there. I'm injecting onto the suprascapular nerve. You can relax. Are you feeling lightheaded or dizzy or anything?
No, I'm not.
I'd like to say something. Many of my procedures I do sitting up, which is what many practitioners will not do out of fear for vagal. I've almost never had a vagal in this position with these particular injections. Where the vagal reaction has occurred, the syncope or the near syncope, has been mainly with cervical facet injections. And I'm guessing part of that is because in the facet you could have communication with the epidural space, and the patient could feel faint or dizzy. It could still happen with what I'm doing, and I advise caution. I'm not telling everyone to sit patients up because there is a risk of vagal. I've been doing this for 17 years, and I have a sense of who to do this with and who not to do this with. I know her. She's had a good history of receiving injections without feeling faint, as well as the fact that she's on a table where I'm prepared to lie her down if she becomes lightheaded or dizzy or has any signs of bradycardia or hypotension.